SwayamPrabha. Digital India. Educated India.
Welcome. In this session, we will learn about the pathology of alcoholic liver disease. So, this can be studied under the categories of pathogenesis, including predisposing factors and mechanism of liver injury, the stages, the types, then the morphology of the different stages or types, clinical features and the laboratory investigations. So, what is alcoholic liver disease and why is it important to learn all about it? Now, alcoholic liver disease is increasing day by day because of the increasing consumption of alcohol. Now, alcohol as such causes liver injury, and that is why we get chronic liver injury or chronic liver disease as the most important manifestation here, and alcohol has become one of the most common causes of chronic liver injury, besides being responsible for approximately 5.9% of global deaths. So, what is alcoholic liver disease? Basically, it is just a maladaptive response to a stimulus, that is alcohol, by the hepatocytes, which is in an increasingly progressive manner, and approximately 8 grams per day is considered to be a threshold in most people, though some may vary, and the individual responses are they differ according to maybe ethnicity, etc. So, that is what we were going to see initially about these responses. So, pathogenesis wise, the normal liver, when a person imbibes alcohol, undergoes fatty change, and this is known as steatosis. Besides that, whenever there is abstinence, the patient may or the liver may go back to normal. Now, severe exposure gives rise to an inflammation of the liver, which is known as acute hepatitis or alcoholic hepatitis, steatohepatitis also, because there is an existing fatty change also in the liver. And similarly, when the patient abstains from alcohol, then the liver may go back to normal. Now, what happens if there are repeated attacks of acute hepatitis, that is alcoholic hepatitis in the patient? Then it will progress to scarring or fibrosis, and repeated such attacks will lead to more and more fibrosis. In the end stage, it gives rise to alcoholic cirrhosis. Similarly, continued exposure in a patient who has got alcoholic steatosis can also lead to cirrhosis. Now, sometimes hepatitis, when a patient abstains, it may revert, instead of going back to normal, it may go to the steatosis phase, and likewise in a patient with steatosis, in repeated exposure to alcohol can give rise to alcoholic steatohepatitis. So, in this way they are interrelated. Now, let us have a look at the predisposing factors. 3 most important categories are there amongst predisposing factors, and they include gender, ethnicity and genetic factors, and comorbid conditions. So, first let us have a look at the gender. It has been noted that females do not metabolize alcohol as easily as the male gender, and that is supposed to be a response to estrogen. So, what does estrogen do? Now, estrogen, besides causing an increased absorption of alcohol in the intestine, it also gives rise to increased absorption of endotoxins, that is lipopolysaccharides from bacteria in the gut. Now, these in turn go to the liver, and there it binds to the receptor on Kupffer cells, that is CD14. Now, this in turn causes toll-like receptors to be activated, and these will release cytokines, chemokines, etc. from the Kupffer cells. Now, as we know, when there are cytokine and chemokine release in any part of the body, it acts as a chemoattractant, and therefore white blood cells or your leukocytes will come to that area and there will be inflammation. Likewise, it happens in the liver also. So, this is how gender bias is there in alcoholic liver disease. Next, ethnicity and genetic factors. As in all other diseases, genetics play a big role as well as the ethnicity of the person. Now, in alcohol, it has been noted that it is African American individuals are more prone to have chronic liver disease as compared to others. Now, this could be due to genetic polymorphisms in the enzymes associated with metabolism of alcohol and also cytokine promoters. Now, certain ethnic individuals have predisposing factors, especially in Asians. It has been noted that those with the ALDH2, that is acetaldehyde dehydrogenase 2, and if they are homozygous for this particular enzyme, then in that case they have very low activity and therefore acetaldehyde is not oxidized. So, this results in intolerance to alcohol, and these patients will have flushing, then uneasiness, etc. Now, comorbid conditions can also cause an increase in liver disease in people consuming alcohol, especially those conditions which affect the liver more often, for example, hepatitis, HBV and HCV in particular, then iron overload and non-alcoholic steatohepatitis. So, what is the mechanism of hepatic injury? Now, alcohol produces hepatic injury by its effects on the liver, which include steatosis, dysfunction of membranes, that is of the cell as well as mitochondria, oxidative stress and hypoxia, which in turn give rise to inflammation and therefore hepatocyte death. Let us have a look at some of these aspects. So, the first one is the mechanism of hepatic steatosis. The basic mechanism is that whenever a person consumes alcohol, there is an increased lipid pool in the circulation. So, how does this happen? So, ALDH, that is your acetaldehyde dehydrogenase or aldehyde dehydrogenase and alcohol dehydrogenase are activated. Now, activation of these two enzymes gives rise to increased NADH generation. Now, this is responsible for lipogenesis induction by suppression of fatty acid oxidation and increase in enzymes for fatty acid synthesis. Besides this, alcohol also causes an increase in triglyceride production and increased peripheral catabolism of fat and impaired assembly and secretion of lipoproteins, which means that an excess amount of lipid is there in the circulation as well as in the hepatocytes. So, some of the other contributory factors, most important one is acetaldehyde. Now, this causes two important effects, and that is induces lipid peroxidation and it also produces an acetaldehyde protein adduct. Now, this acetaldehyde protein adduct is deleterious to the hepatocyte because it disrupts the cytoskeleton and membrane production function and therefore gives rise to neoantigen production within the hepatocyte. So, these neoantigens are foreign to the immune system and thereby an immunologic attack is started or is induced. So, this is how an immunologic attack is induced because of acetaldehyde. Now, the next one and the most important one is also cytochrome P450 induction, in that specifically CYP2E1, and these are present in the microsomes. We know that in alcohol consumption, the membranes of different organelles are also involved or are also attacked. So, and therefore, microsomes are also involved in this condition, and the enzymes there are released. Most specifically, cytochrome P450 is induced, and this gives rise to damage of the hepatocyte cytoskeleton. Furthermore, it also causes increased drug conversion to toxic metabolites and generates free radicals. Now, these free radicals are the ones which damage the hepatocyte cytoskeleton. So, this gives rise to apoptosis of the cell, and besides that, hepatic injury can also be caused because of inhibition of functions of specific oxidases. So, this when the oxidases are inhibited, a lot of drug toxicity is induced because drug clearance is reduced. So, further going on to the other contributory factors, these include impaired catabolism of methionine, and methionine we know gives rise to glutathione. Therefore, there is reduction intrahepatic glutathione, and this gives rise to your sensitization of the liver to oxidative injury. Okay. Another contributory factor in hepatic injury is the excess production of homocysteine due to impaired catabolism of methionine, and this in turn gives rise to stress response being altered and increased in endoplasmic reticulum. Now, we will move on to the stages of alcoholic liver disease. As I had mentioned earlier, there are 3 distinctive overlapping forms of alcoholic liver disease. These include hepatic steatosis, alcoholic steatohepatitis, and fibrosis. Now, one usually leads to the other, or we may get the patient to be presenting in hepatic steatosis or as alcoholic steatohepatitis. Rarely these 2 phases can be very subtle, and the patient may present directly to us with cirrhosis or fibrosis. So, before moving on to the morphology, let us have a look at the functional unit of the liver. Now, in the liver, we call this a lobule. It is a hexagonal structure, and at each angle of the hexagon there are the portal tract comprising the bile duct as well as the vessels, and in the middle is the central vein. Now, according to the your vascularity, the zone very nearest to the vessels is known as zone 1 because it receives the maximum amount of oxygen, and the zone nearest to the central vein is known as zone 3, and it receives the least amount of oxygen. So, as far as alcohol consumption is concerned, what happens is the zone nearest to the central vein will be the first to be affected because it has the least amount of oxygen, and therefore, it is more prone to injury. So, that is known as the centrilobular zone because it is in the center of the lobule. So, alcoholic steatosis is fatty change, and it is characterized by a large liver. So, it begins in the centrilobular zone as I said earlier, and it extends outwards from that. It is an early effect of alcohol. The liver can be up to even 4 to 6 kgs in size, and another thing is because it is a fatty liver or steatosis as we call it, it is quite greasy and yellow in color. Okay. Alcoholic steatosis is characterized microscopically by accumulation of fat within individual hepatocytes as small vesicles, and that is known as microvesicular. Now, these vesicles will coalesce and form large vesicle, and therefore, it is known as macrovesicular, and this is the predominant pattern in alcoholic steatosis. These macrovesicles will push the nucleus to the periphery. So, this starts, as I said, everything in alcoholic liver disease starts in the zone 3 or centrilobular zone. Now, this change is reversible, and initially a little bit of fibrosis may also be seen, and this fibrosis starts around cells and then progresses to sinusoids and perivenular, and then it reaches outwards towards the portal tract in later stages, in the remaining 2 stages, that is. Unusually, if there is chronic heavy use, we may be able to see foamy degeneration with a lot of microvesicles which have coalesced. Now, this is a special stain which we do to look for fibrosis. It is known as Mason trichrome. In this we can see chicken wire type of fibrosis around individual cells, and it is started to line the sinusoids also. There is also slight amount of perivenular fibrosis. So, next we move on to another stage, that is alcoholic hepatitis. This occurs in a subset of patients, and it is an acute necrotizing lesion. Remember, alcoholic hepatitis, so which means inflammation of the liver. So, you will get in this necrosis, a degeneration, specific type of degeneration known as ballooning degeneration, which starts in the centrilobular zone, then certain degenerating cytoplasmic cytokeratins which are known as Mallory-Denk bodies, neutrophilic inflammatory response, and perivenular fibrosis. So, hepatitis, in this let us have a look at the gross. it has a mottled red appearance, it is an inflamed liver. So, that is why the color, and it can be bile stain because of minimal amounts of cholestasis that is associated with this condition. Size may be normal or increased. Now, microscopically you will get ballooning degeneration as shown in this picture, in which it starts again in the centrilobular zone. Now, in this the hepatocyte is enlarged and shows clear cytoplasm. Sometimes you can get necrosis also. Now, wherever there is necrosis, the hepatocyte disappears in that area, and that area is filled up by neutrophils, which we call as spotty necrosis or spotty degeneration. Now, what is Mallory hyaline? Now, this Mallory hyaline is nothing but cytoplasmic hyaline inclusions. These are degenerated or degenerating tangled skeins of cytokeratin, especially the intermediate filaments CK18 and 8. So, these are eosinophilic in color in hematoxylin and eosin stained sections. Now, whenever we get Mallory hyaline and ballooning degeneration, we also have to rule out other conditions. This is, I am talking about the microscopic features. The other conditions include non-alcoholic steatohepatitis, Wilson's disease and chronic biliary tract disease. Inflammation and necrosis is yet another feature in alcoholic hepatitis. The necrosis is spotty, rarely multiple cells may be involved, and then it can become confluent. The neutrophils initially start as satellitosis, that is, they go around degenerating hepatocytes and then fill in the place where the hepatocyte has necrosed. Lymphocytes and macrophages can also be seen, but the amount is not extensive as the neutrophils, and these lymphocytes and macrophages may be restricted to the portal tracts, or they may spill over from the portal tract into the adjacent hepatocytes, or sometimes in the remaining parenchyma also. Fibrosis, when seen here, is again similar to alcoholic steatosis, but a little more than that, and it is usually sinusoidal and perivenular. Cholestasis is a new feature which starts in alcoholic hepatitis, because there may be some amount of damage to the canaliculi also, as well as to the bile ductules. So, this is the neutrophils which have gone around degenerating hepatocytes, and this is ballooning degeneration here, and inset shows a special stain, that is immunohistochemical stain for cytokeratins, which are seen around the nuclei in the cytoplasm. So, it has taken up a brown stain here, CK8 and 18. So, this is Mallory hyaline, which is seen as a eosinophilic dense irregular body here. Sometimes it can be rounded, but usually it is quite irregular, maybe C-shaped also, and perinuclear. Now, we move on to the last stage in alcoholic liver disease, which is alcoholic cirrhosis. This is an irreversible stage, and it progresses from alcoholic hepatitis or from alcoholic steatosis. So, as a result, initially it may be a large liver with fatty change as well as yellow tan in color, but later on at the end stage it becomes non-fatty, brown and shrunken as here, and then there will be extensive nodularity, the surface may be irregular. Now, these nodules may be small in size, less than 3 millimeters when we call it micronodular, or more than that when we call it macronodular. Okay. So, now we move on to the microscopy of alcoholic cirrhosis. So, microscopically it is a scarred liver. So, you will get multiple gravite scars in the liver grossly, and microscopically you will see them as bands separating the nodules of hepatic tissue, and there is a loss of the usual lobular architecture. So, the fibrosis initially it will be centrilobular, then it progresses to perisinusoidal, that gives rise to a chicken wire kind of appearance, and then it progresses periportal, then central to portal, and finally you get multiple nodules. So, if this is typically micronodular, it is known as Lennec cirrhosis, which is seen in this condition. New perisinusoidal fibrosis may also occur, and this is a progressive phase. Now, the microscopic picture seen here highlights these fibrous bands in blue, and this is a special stain known as Mason trichrome stain. What is pink is the hepatocytes. So, this is a picture again of Mason trichrome staining, and this is your micronodular cirrhosis, which when the patient abstained almost reverted back to normal. So, you can see that there are very few scars and very thin fibrous tissue here. Now, clinical features of these different conditions. Initially, we will have a look at what happens clinically in steatosis. So, in clinical features, it includes both the clinical presentation as well as what the biochemical or laboratory investigations show us. So, the first one, that is steatosis. There is just hepatomegaly mild. The patient may or may not present at this stage, but in this stage if the patient presents and we do the laboratory investigations in the blood or in the sera, we see that bilirubin is increased, serum alkaline phosphatase is increased, the transaminases, or in other words the serum aminotransferases, that is AST and ALT, there is a more increase in AST as compared to ALT. Both are increased, but then the AST is increased at least by a ratio of 1 as compared to ALT. Now, what they have said or what they have noted is that GGT, that is your gamma glutamyl transpeptidase enzymes, are elevated. This is something to do with the liver injury, that is within the hepatocytes the organelles are injured, and that is where GGT is produced. So, as a result of that there is an excess amount of GGT. So, this occurs exclusively in alcoholic liver disease in the initial phases. So, this can be helpful in detecting early cases of alcoholic liver disease. Next one, in hepatitis, this occurs following heavy drinking, and it could lead to mild hepatitis, or it could even progress to acute hepatic failure, or patient may even present with acute hepatic failure. Now, mild cases usually have only generalized symptoms like nausea, then bloating, anorexia, malaise, weight loss, etc., and abdominal pain will be a common feature, and hepatic tenderness will be elicited whenever we look for signs of mild hepatitis. In severe cases, it can give rise to acute hepatic failure or acute cholestatic syndrome. Now, repeated attacks will lead to either cirrhosis in 1/3 of the patients, but in 10 to 15% it may give rise to even death. So, laboratory investigations in this phase include an increase in bilirubin. Now, AST is elevated more than 2 times of ALT. This is very typical of alcoholic liver disease. In chronic liver disease due to other causes, it is the ALT which is increased more than AST, whereas in this, that is your hepatitis, it is AST, hepatitis as well as in cirrhosis, AST is elevated more than double the time with the elevation of ALT. Neutrophilia will also be evident in this case, and your prothrombin time will be increased. So, these are the features seen in laboratory investigations in the blood. When you do urine examination, you will see bilirubin as well as urobilinogen. Now, we move on to the last phase, that is cirrhosis. The clinical features of cirrhosis are classically those of portal hypertension, which include ascites, splenomegaly, spider angiomas as well as jaundice. Now, biochemical investigations are similar to acute hepatitis, with the exception that some other elements are also reduced or increased, and this include globulins which are elevated. So, there will be hyperglobulinemia. Hypoproteinemia is seen with albumin reduced, then clotting factors markedly reduced, and therefore, increased prothrombin time, and anemia of chronic disease comes into play. Now, let us have a look at the cause of death in patients with alcoholic liver disease. It is either due to hepatic coma or massive gastrointestinal hemorrhage, especially from the esophageal varices. Then cirrhosis is a precursor lesion for hepatocellular carcinoma. So, a patient may die because of hepatocellular carcinoma. Intercurrent infection is common in these patients. Hepatorenal syndrome can also be a cause of death. And now, with this we come to the concluding part of this session. So, let us summarize what we have learnt in this session. Alcohol consumption accounts for 5.9% of global deaths. In the West, it is the leading cause of liver disease. The three forms of alcoholic liver injury include steatosis, steatohepatitis and fibrosis. Mechanism of injury is most importantly due to acetaldehyde formation and CYP, which is a cytochrome P50 enzyme, CYP2E1 induction, altered lipid metabolism and inflammation. So, these three are most important in causing injury to the hepatocyte. Laboratory investigations for alcoholic liver disease, typically there is an increase in LFT, especially AST more than ALT with a ratio of 2:1. Clinically, steatosis presents in a subtle way with just hepatomegaly. Steatohepatitis is acute and may progress to liver failure, whereas fibrosis will end in cirrhosis and the patient is said to have chronic liver disease by that time, and the manifestations would be similar to portal hypertension. Okay, so this concludes alcoholic liver disease. Thank you for your attention. Have a good day.